Welcome back to the Canadian Liver Foundation's 2021 LIVERight Health Forum. I'm very excited to introduce today's speaker, Dr. Natasha Chandok. Dr. Chandok is an adjunct professor at Western Ontario and clinical affiliate at the University of Manitoba. One of her many accomplishments is to have established a successful e-learning app called Learn Deliver. Currently, she teaches at McMaster University and has been instrumental in establishing a hepatology program at the William Osler Health System in Ontario. Today, Dr. Chandok will talk about cirrhosis, symptoms, causes, stages, diagnosis, and treatment. Please join me in welcoming Dr. Natasha Chandok and our host, Valeria Zaborska.
Thank you very much for joining us, Dr. Chandok. It's a pleasure to meet you. So
Likewise.
For our first question, this is from an audience member. They ask, I was told I have cirrhosis of the liver, but I have no symptoms. What does this mean, and what is cirrhosis?
So cirrhosis, by definition, is advanced scarring in the liver. And cirrhosis has many stages. At its earliest stage, patients may not experience symptoms. So I usually explain cirrhosis to patients by a visual representation. So you can imagine if you've ever seen a liver in a butcher, many people have, it's a smooth purple structure. You can't feel any firmness. It's very pliable. Whereas cirrhosis is a stiff, scarred liver, it often may become shrunken over time with advanced scarring. So the person asking this question mentions they don't have symptoms, and one of the pitfalls of liver diseases is that they don't produce symptoms until they are very advanced. So it's very common for patients with very early cirrhosis to actually not realize they're ill.
Okay, thank you. And what causes cirrhosis?
So that's an excellent question. In a way, it depends where you're living in terms of what the most common causes are. But globally, the most important liver diseases are viral hepatitis B and C, alcohol-related liver disease, non-alcoholic fatty liver disease, and finally, in developed countries, hereditary hemochromatosis. But certainly in Canada, non-alcoholic fatty liver disease is by far the most common liver disease. There are actually a myriad of other liver diseases that may lead to cirrhosis. For example, there are several autoimmune diseases that can cause end-stage liver disease. These would include autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and even something like celiac disease would be in that category. And then there are hereditary diseases, for example, hereditary telangiectasia or polycystic liver disease. Wilson's disease is another rare hereditary disease. Even medications can cause cirrhosis, but by far and away, the most common causes are the top four that I mentioned. And again, those are alcohol-related liver disease, non-alcoholic related liver disease, and viral hepatitis.
So it sounds like those who already have a liver disease are more predisposed to developing cirrhosis. So being someone who's diagnosed with this, is there anything that patients can do to prevent themselves from developing cirrhosis, having maybe those top four conditions?
Absolutely, that's an excellent question. And I think we really, all of us who manage people with liver disease really want to put a lot of emphasis on disease prevention, particularly because we don't have good treatments beyond liver transplant for very terminal cirrhosis. So we can talk about each disease and go through preventative measures. Just to begin with, all of us in society, irrespective of what liver disease one may have, should eat a very balanced diet, which is low in processed foods and rich in plants, so lots of fruits and vegetables. There appears to be literature to suggest that a reduction in processed carbohydrates and processed meats is probably very advantageous for our liver health. And of course, things to prevent liver disease would also involve modification in alcohol usage, so avoidance of excess alcohol consumption. And that would vary by gender, but generally 1 unit or more in a female may become problematic. So trying to strive for 1 unit or less on a daily basis, and 2 units or less in a male patient. There are some patients that are very predisposed to alcohol-related liver disease, and we may modify that recommendation, but that would be a general public health recommendation. We also want to make sure that all of us are exercising on a daily basis. As I mentioned to you, non-alcoholic fatty liver disease is by far the most common liver disease in the world, affecting in North America about 1 in 5 patients. So it's really important that exercise be incorporated at least 30 minutes a day. And this is important to reduce our cardiovascular risk, which would be higher as an overall risk in patients with non-alcoholic fatty liver disease. There are other things we can do to prevent disease from progressing to a serious state. It's very important that we all get screened for liver disease, particularly if we have any risk factors. So for example, we want our population who belong to the baby boomer category, or who are immigrants, or who have had transfusions perhaps before the early 90s, to make sure they've had screening for viral hepatitis B and C. Another thing we can do to provide disease prevention is, of course, protecting our human population against hepatitis B. So making sure that we are broadly vaccinating our population. Screening plays a very important role in liver disease. And I want to specifically mention, in addition to screening for viral hepatitis B and C, the importance of screening for hemochromatosis in the Caucasian population, particularly if there is elevated iron on their blood work or a family history of liver disease. But by and large, what keeps us healthy as humans helps prevent liver disease. So it's really important that we go back to basics with good nutrition and regular exercise. There are other things that we could also talk about with patients. For example, I'm thinking about education we need to provide our youth around alcohol, and education we need to provide members of our society around over-the-counter herbal medicines and things like acetaminophen. These are very common medications and supplements, and they often require medical oversight and judicious use. So it's important that we also discuss that.
Great, thank you. Very detailed. So going back to one of your previous answers, you described the 4 stages of cirrhosis and the fact that the first stages don't really have symptoms. Can you tell us what people can look for, what kind of symptoms or signs that they would present with that are suggestive that they're more at a later stage of cirrhosis?
Absolutely. Just before I answer that question specifically, one of the questions that I get from patients a lot is confusion around the word stage and cirrhosis. So just to clarify, cirrhosis by definition is stage 4 fibrosis in the liver. And what that means is, under the microscope, the liver will have a nodular appearance because the fibrosis or scar tissue has formed rings. And the cirrhotic liver almost looks like a cluster of grapes, so a very bumpy situation. Now, there are different ways to further subclassify cirrhosis for us to understand what a specific patient is experiencing. And one of the ways is a 4-point scale, which I must confess I don't prefer to talk to patients in that jargon because I find it confuses them. And I like to use an older categorization called the Child Q score. And this is something that our listeners will be very familiar with if they've done any internet searches about cirrhosis. So in that categorization, we divide cirrhosis into three groups, A, B, and C. A meaning the mildest and C meaning the most severe. And when I explain things to patients with respect to their cirrhosis and what stage they're at, I actually use the words mild, moderate, and severe cirrhosis to replace the A, B, and C. So if somebody has mild cirrhosis, that's like our initial question. That person, if you or I were looking at them, they would not appear ill. So they would not have yellowing of the eyes, advanced muscle wasting, confusion, fluid around their belly, which we call ascites. On the other hand, somebody with severe cirrhosis or child C cirrhosis, they would have all of those symptoms and they would look very unwell, even to a layperson. And child B is the middle category where people will have signs of liver failure, which a doctor or even a layperson would be able to see, but it won't be advanced as the child C patient. Now, just getting back to the question, which was a very good one, I believe they're asking about the 4 stages of cirrhosis. So I've explained it to you as a 3-stage response, but the 4 stages refers to the following. At the earliest stage, patients don't have varices or ascites. Varices are veins that form typically in our esophagus and stomach in the process of having cirrhosis. When somebody moves into stage 2, the first thing that happens is they develop these varices or veins. They look like varicose veins when you do an endoscopy, but they don't have ascites as yet. In stage 3, the patients with cirrhosis at this stage will have both varices and ascites. And the final stage is where they have complications from these entities. So they will have bleeding or rupturing of the veins that have formed through the pathology of cirrhosis. They will develop infection in the fluid that's accumulated around their liver. And very frequently, they will have mental status changes, a fluctuation in level of consciousness, which we call hepatic encephalopathy. So that would be the final stage of cirrhosis. And the idea is that once we identify cirrhosis, we want to intervene as early as possible to try to stabilize patients and also to identify who may require a transplant before they progress too deep in that pathway, because we know that as one passes through this pathway and develops stage 4 fibrosis, their mortality rate becomes very, very high.
And in terms of, so being between these different stages, are there any tests or imaging that you use to diagnose cirrhosis and to stage it?
Absolutely. So the first thing that clinicians will always do is the very basic history and physical exam. And often those 2 interventions will be very revealing if somebody has cirrhosis. But there are specific diagnostic tests, and we can discuss them in the form of laboratory investigations as a first category, imaging investigations, and finally procedures. So that would include endoscopy and liver biopsy, which may or may not be necessary. So lab investigations will be very revealing. Typically, a liver doctor like myself would screen patients for multiple liver diseases, including all of the ones we discussed earlier. And we would specifically measure liver function. Liver function is measured in blood work by lab tests such as bilirubin, albumin, and INR. With regards to imaging, imaging plays a very, very important role in the diagnosis of cirrhosis. And the most important imaging modality that we rely on is actually a liver ultrasound. An ultrasound is usually sufficient to diagnose cirrhosis, and it would reveal a coarsened or nodular looking liver. And often when this happens, the neighboring spleen, which is an organ that sits in the left upper quadrant of the abdomen, it often enlarges. And with advanced cirrhosis, as I alluded to, patients may develop ascites, which is the medical term for fluid in the peritoneum. And then moving on to further diagnostic tests, we do have a non-invasive tool at our disposal called FibroScan, or transient elastography. And this is a ultrasound-based technology which literally takes 5 minutes. It doesn't cause any pain to a patient, and almost every patient is a candidate for a FibroScan. And a FibroScan can rapidly tell us within a matter of under 5 minutes whether somebody has cirrhosis, or in fact to stage their disease out of 4. So fibrosis is measured out of 4, and again, cirrhosis is 4 out of 4. Liver biopsy, although not required for the diagnosis of cirrhosis, is required in certain liver diseases, specifically autoimmune liver diseases as an example. And a liver biopsy does remain the gold standard for the diagnosis of cirrhosis, but thankfully not necessary in the majority of patients. And finally, I do want to mention endoscopy. Although endoscopy is not how we diagnose cirrhosis, endoscopy is very important because it allows us to assess portal hypertension. The presence, for example, of esophageal varices or gastric varices tells us a lot about what stage someone's liver disease is at. And in fact, an endoscopy is indicated when we make a diagnosis of cirrhosis. So just to conclude, often we get a tremendous amount of information from history and physical, and very frequently we simply need, for the majority of patients, standard blood work and an ultrasound to confirm the diagnosis.
So you mentioned portal hypertension as sort of one of the signs that you have cirrhosis. Can you explain, maybe say in layman's terms, for me, a student, how that works?
Absolutely. So portal hypertension refers to elevated blood pressure around the vasculature of the liver. So as humans, we have some degree of a hepatic venous pressure gradient. It's actually normally about 6 millimeters of mercury. And what happens when we develop cirrhosis? We have a mechanical obstruction forming inside the abdomen. And we also have some complex physiological events which occur. These would include what we call splanchnic vasodilation, which is dilation of the blood vessels in the abdomen. And we also have vasoconstriction within the liver from a hormone production called endothelin-1. And not to bore the audience too much, but what cirrhosis does is, imagine a garden hose and I pinch that hose, and suddenly the flow of water is restricted and the pressure of water in my restricted hose is very high. That's very much what's happening inside the liver with cirrhosis. And the more fibrosis or scar tissue in a patient's liver, the greater the pressure or greater restriction on that garden hose. And what happens is, as this portal pressure rises, patients' complications rise and their mortality rises. And these complications, again, include internal bleeding from veins. So we have, all of us have veins in our esophagus and stomach, but blood should normally flow downward through the liver. But with that constriction, blood is now flowing backwards, and these veins start to fill and they can burst and bleed. And we call that event a variceal hemorrhage, and it's associated with a very high fatality rate. What also happens in this scenario of portal pressure is patients develop ascites, which is the fluid that one can develop in the peritoneum. The presence of ascites is a very, very important event in the natural history of cirrhosis. Once ascites develops, patients generally need consideration for a transplant. And what can happen with more and more elevated portal pressure is patients can get spontaneous infection in the ascites. We call this event spontaneous bacterial peritonitis, which is a very dangerous infection that happens in this fluid. And finally, with greater portal pressure, we have less clearance and detoxification happening in the liver, and patients get worsening confusion or encephalopathy.
So, are there treatments for cirrhosis? So, you mentioned liver transplant, which I suspect is one of the later stage treatments. Is there anything, any medications or something you can do if you have cirrhosis in the meantime before having to proceed to a transplantation?
So cirrhosis is unfortunately um, an irreversible amount of scarring. So it's an insoluble amount of scarring in the liver by definition. However, depending on the underlying cause of cirrhosis, there may be treatments that we can offer a patient which may actually improve the health of the liver tremendously, even if that patient is cirrhotic. So I'll give you an example. Somebody could present to a liver doctor or liver clinic and have cirrhosis from hepatitis B. And thankfully, hepatitis B is an imminently treatable disease with oral medications. And once the virus is well controlled with medications, the patient may actually have a reduction in portal hypertension and an improvement in liver function. We also see dramatic improvements in cirrhotic patients who may present with alcohol-related liver cirrhosis and stop alcohol consumption. Or another dramatic example that I would see frequently is somebody who presents with autoimmune hepatitis with cirrhosis, and we control the autoimmune hepatitis, and this can result in a substantial improvement in their overall liver function. You are quite right that the only treatment for terminal cirrhosis that will work is a liver transplant, but it's extremely important that we medically optimize patients as much as possible. And very often what that would mean for a patient is the difference between needing a transplant and maybe not needing a transplant. So in going from a state of decompensation to a state of compensation. I hope in the future we will have antifibrotic drugs. So these would be molecules that would actually help dissolve the scar tissue of cirrhosis. But right now, those types of interventions are at early trial phase, and there is nothing close to coming to market, which will be essentially a medical cure to cirrhosis.
Wow. So it also, from what I've heard before, the teaching was that once you have cirrhosis, you can't really go back. But I feel like that may have changed. Can cirrhosis regress back if you get the treatments for your underlying condition and if you eat healthier, etc.? Can you actually, without the medications that you mentioned for the future, regress it?
That is a very interesting question. So I would generally tell patients that cirrhosis, true cirrhosis, so nodularity of the liver, is unfortunately irreversible. But the actual health of the liver can improve. So let's go a little bit back to one of the earlier questions where we were talking about the stages of cirrhosis. So it is possible with medical optimization, depending on what type of disease we're dealing with, and sometimes depending on a specific patient. But it is possible that patients may go from advanced child C cirrhosis to child A cirrhosis. Now, I certainly have had very small number of patients, and I'm sure many of my hepatology colleagues have, who we felt were cirrhotic, but through medical optimization moved out of that box and regressed. But that would be the exception rather than the rule. So I think if a patient out there has been diagnosed with cirrhosis, especially if they have had ascites and varices, which would be events which occur later in the disease course, then that patient is someone we would want to counsel them that their diagnosis is a chronic disease. And it would be, I think, a false pretense to tell patients that it can go back to normal. But we can certainly often help patients maintain compensated state with medications depending on the specific situation of the patient. But what I'm trying to say also in this long answer is if somebody has cirrhosis, it's really important that they make sure they keep careful follow-up with their provider, because they do need the careful monitoring to make sure that patient remains optimal, and that we're providing all of the appropriate screening that we can, so that if that patient does ever require a transplant, or God forbid has some event like development of liver cancer, we want to pick things up as early as possible to give the patient the very best outcome.
Great. Well, thank you so much. Maybe we just have about 1 minute left. The last question from the audience was, as a liver specialist, would you recommend the COVID vaccine for patients living with liver disease or cirrhosis?
That is an excellent question. So the short answer is I would recommend the vaccination to all patients with chronic liver disease, cirrhotic or non-cirrhotic. There are no specific studies that have specifically looked at cirrhotic patients, but at this point, as you may well know, millions and millions of patients around the world have had the COVID vaccine, and we've not seen any post-marketing data to suggest any danger to cirrhotic patients. And I just want to remind our listeners that cirrhosis is an immunocompromised state. The liver plays a vital role in our immune system, and it's very important that we protect our patients with cirrhosis and make sure that they not only are vaccinated, but hopefully reap the benefits of herd immunity, because we know that cirrhotic patients do have worse outcomes with the COVID infection.
Great. Well, thank you so much for your time. It's been a pleasure.
It's been my pleasure as well. Thank you so much.